Hello, welcome. I'm going to be speaking to you about nutritional management of allergies. My thanks goes to Spectrum, who gave me this opportunity to speak to you. I don't have a relationship with Spectrum currently, but certainly I'm very passionate about this, and I'll give a little way of background about my training and experiences that will inform my presentation. So first of all, I'm a board certified veterinary nutritionist, which means I'm a diplomate of the American College of Veterinary Nutrition. I'm also founder of Balance It. We provide free online software for folks as well as supplements to fortify human foods when fed to pets, both in wellness and in sickness. Was founded in 2003 and is used by just over 20,000 veterinarians. A large portion of that, as you can imagine, is for folks who have patients or pets who have food allergies. I'm also founder of Vet Assistant AI. I'm a board member of the American College of Veterinary Nutrition currently, and also the Mark Morris Institute, also known as MMI, which is a nonprofit that provides nutritional education at vet schools throughout North America and the Caribbean. I'm currently a council member for Petco's Pet Wellness Council, and we help inform the Petco leadership on issues related to veterinary medicine and pet health and wellness. I'm the chair-elect of the AVMA, a Veterinary Specialty Organization Committee, or VSOC, which represents 22 veterinary specialties and over 13,000 veterinary specialists. I'm also the primary residency mentor for Yuki Okada, who has both a DVM and a PhD at a referral hospital north of San Francisco in Marin called Pescom. And that informs a lot of my current thinking as we see patients regularly with food allergy. I'm also the co-editor of Applied Veterinary Clinical Nutrition. It's a textbook that is written by a lot of my colleagues who are also board certified veterinary nutritionists in their areas of expertise, covering a lot of the topics, including food allergy. And finally, I am a former clinical faculty member from UC Davis, where I saw clinical cases for over a decade. Prior to that, I was a resident there, as well as a student. I also did my master's in nutrition at UC Davis. So what are my goals? What are my goals for what we're going to talk about? Really, it's to help you better practice when you have a patient that has food allergy. I think we all feel comfortable with the underlying pathophysiology of allergies, but I'll briefly talk about that and how it relates to nutrition. I want us all to be able to list some common symptoms of allergies. Some of them I think are very apparent to us, some maybe not as well recognized, or at least by clients. And then understand the value of diagnostics and where they may fail us and what we can use them for. Distinguish among the different treatment options that are available to us nutritionally, especially, and then kind of get a comfort with monitoring response. And then this last one is really what I want to hone in on with mastery of treatment adjustments based on response. And I think all of us can do a lot of 1 through 5, but it's when things don't go as well as we might have initially hoped with a recommendation or a solution, is how do we adjust to help the patient get some relief. So if we think about pathology, food allergy, we just think of allergy as kind of a damaging or an inappropriate immune response to an antigen. And the way I often kind of describe that to clients is to think of the food antigens as being seen by the body as something that's an invading species. You know, it's a bacterial load, a parasite load, a viral load that the body goes, I've got to defend against. And they don't realize that it's really that they've just lost oral tolerance. And oral tolerance is the concept that as you eat foods, they have proteins in them. And it's not just the animal protein or even a vegetable protein that are rich in proteins, but there's proteins from carbohydrates. And the body can see those proteins as, you know, something foreign and then react to them. But normally they should say, oh, this is food. I need to break it down into peptides and amino acids to use in my body for energy or for building blocks of things I'm going to make. When that oral tolerance has been lost, again, it results in just an overstimulation of the immune response. And if we think about the lining of the intestinal tract, it's extremely well protected with immune cells because it is a huge surface area to do all that digestive and absorptive processes. And so there's just a huge opportunity to infiltrate a body, and so the immune system's there ready to defend quite readily, quite quickly, if there's something that they feel is going to infect. And so the manifestations of this overreaction, if we will, to things that should be tolerated is either GI signs or dermatologic signs. And those GI signs and dermatologic signs can be pretty profound. Sometimes they can be a little bit more subtle. They can start subtle and become more severe. But if we think about specific dermatologic signs, we need to think about there being a threshold. And so what this is giving us in this slide is this kind of idea that there is a point at which there won't be any itching, even if there is some allergens. But at a certain point, that overcomes a threshold, a point at where pruritus or itchiness starts to become a clinical sign and a concern. And so when we think about the three main antigen sources for those dermatologic signs or that pruritus, we can think of fleas, we can think of pollen, mold, dust, and we can think of food. And fleas with adult flea preventative or adulticides, we can hopefully minimize the risk of a bite inducing some itchiness. Pollen, mold, dust, environmental antigens are really very challenging. And so removing them from the environment or controlling that can be much more challenging, much more labor intensive. And then finally, food. And a switch in food, if there is an underlying component where they have a food allergy, by switching the food, that might bring them below the threshold. And so usually fleas and food are managed first, and only later do we try to deal with pollen and mold and dust if that removal of those sources of antigens, the food, the fleas, is inadequate to bring them under control and provide them relief. So let's talk about the clinical signs that we see. From a GI perspective, we certainly all, I think, are very aware of diarrhea and vomiting. It's very apparent to clients, but there can also be other less obvious signs. And so it could be just an increase in defecation, frequency and volume. It could be hyporexia or reduced appetite. Sometimes that manifests just as selective eating and not eating as readily foods that were offered once and enjoyed. It can be seen as being finicky. There can be increased salivation. It doesn't necessarily need to be around the mealtime. There can be eructation, borborygmi for those, we kind of think of those as burping and gut sounds. I used to always joke when I was in vet school, they call those $20 words. If you can say eructation or borborygmi, it enables you to increase your bill to the client. Obviously, I think that's more in jest, I hope. I certainly didn't use that, but I always think of borborygmi as one of those fancy words just to say gurgling. Sometimes, their stomach is rumbling, those types of things. Abdominal discomfort, and clients might notice that in posturing, that maybe, them looking uncomfortable, just not settling. And then finally, flatulence. And those are all GI signs that can be seen. They may predate the more severe evidence of diarrhea and vomiting. And then, of course, pruritus. And if we combine pruritus or itchiness, which might be, licking of the paws, it might be chewing on themselves, other parts of the body, rubbing themselves. If we combine that with GI signs, our suspicion of an underlying food allergy greatly increases. So an animal that has both skin and GI signs, you would raise that in your rule out list. So we think about the diagnostic options that are available to us. We have quite a few things that we can consider. Certainly the first and starting point is just a review of the medical record, a good history of what has been happening. So the symptoms, certainly in relation to the diet at the time. So if we can connect a worsening of signs or the presence of signs or the initiation of signs with a specific diet, that can be very helpful for us identifying things that may not be tolerated. In addition to that, we really want to have more detail on the diet history. And the diet history has a very high value only though if it's complete and accurate. So if we know what was fed when, or what the past exposures have been, that can give us really insight later on when we start making recommendations about what to avoid, and what may still be things that would be tolerated or um, uh, uh, not eliciting of any clinical signs. Certainly, we always want to, do a fecal. We may want to do some type of histopathology where we, look at GI biopsies. We rule out parasitism, try to determine what is the underlying pathology, and make sure that we're not, you know, looking at food as the culprit when in fact it's just a red herring. And then finally, blood testing. It's certainly something that has historically been considered not as reliable or specific. There are new technologies that are being developed, and I would certainly encourage you to contact NextMune or Spectrum, as we've known them for in the past, and better understand the new capabilities of that. I think that we know that there is no perfect test. The gold standard remains an elimination and challenge diet trial, where we eliminate things that we think the patient's been exposed to in the past. We look for resolution of those clinical signs, and then we re-challenge. In practice, it really is hard to get people to do a challenge once they've had success. You can imagine an animal that has been just so uncomfortable with itchiness, or the challenges with vomiting and diarrhea, and the poor patient and the discomfort that comes from that, and just the practical matter of having diarrhea or vomiting that you might have to be cleaning up as well. And so clients, rightfully so, can be very reluctant to challenge with things once they've been eliminated. The disadvantage of that is it's really ever fully can get a definitive diagnosis without it, and it might eliminate a large group of foods that are still tolerated and then are avoided for the rest of a patient's life for fear that they could elicit some of these difficulties. And so the gold standard remains, and the best practice is an elimination and then a challenge diet, if at all possible. Definitely elimination. It can be informed with all the things in white here, the diet history, potentially testing, but really ultimately the proof is in the pudding. The patient's response to an elimination, does that help? So we talk about making this diagnosis, and then faced with this diagnosis, what are our options? So we have a patient we believe may have a food allergy that we'd like to treat with a diet change, and how do we go about doing that? Well, there are three options. Each have advantages and disadvantages, and we'll go over them a little bit more in depth, but just as a kind of a overview, we have novel and uncommon antigen commercial foods. And so novel is defined by the patient, not by the food. So what I mean by that is new to the patient. I had a resident many years ago who had come from Australia, and he had been practicing for a while before he had come to do his residency. And at that time, and we're going now, almost 30 years ago, he would in Australia sometimes use chicken and corn-based diets as a novel antigen diet. Certainly something even back then that in the US we wouldn't, because of its ubiquity, its commonness, its frequency of being fed to patients, so that we don't think it would be novel or new to them. But kangaroo meat, or roo as they would call it in Australia, would not be reached for because it would be more commonly fed. And so the definition of novel is really important to remember, new to the specific patient. We don't always get great diet histories, as I alluded to before. They may not be accurate, they may not be complete. And so we struggle at times, and we'll talk a little bit about the potential for ingredient declarations or lists to not be complete or representative of what may be in foods. And so we also sometimes just think of things as uncommon antigens. What I mean by that is things that are not as commonly used in the pet food supply or found in pet foods. And those can be used to our benefit because the likelihood of them being novel or new to the patient is high, because they just aren't really very frequently fed. They certainly are the easiest in general. Unfortunately, these commercial options are limited. There's only so many unique combinations or pairings of uncommon or novel antigens. And certainly, as over-the-counter foods have started to use some of those ingredients, some of them have become less useful to us in clinical practice. What do we then reach for as an alternative? Well, one of the alternative is hydrolysates. So hydrolysates are also commercially available. They are basically proteins that have been cleaved or broken down into such small pieces that if we think of the key and lock of an antibody antigen, that we hope that the key, the antigen, the dietary protein, has been broken into such a small piece that it no longer can be seen by the antibody that the body and the immune system has created for it, and it doesn't trigger an immune response. Unfortunately, they're not fully hypoallergenic, and why I say that is that if we hear about the way that they're marketed correctly, they talk about kilodaltons, and that's just a molecule size, and it's an average, and it's a bell-shaped curve. And so this process by which they're hydrolyzed or cleaved or made into small pieces of peptides or even sometimes amino acids or some amino acids is not perfect. And so some intact protein can still be present, and that might be enough to elicit an allergic response. And so the smaller the molecular size, the better, but they're certainly not perfect. They've not been broken down completely into just peptides or into amino acids. They may have some additional purity, as we'll talk about from some research, so there may be some advantage to them. Certainly can be very helpful when diet history is a little bit less clear. And then finally, less convenient, because the previous two are commercially available, is a homemade diet. And that can be using novel or uncommon antigens. Novel meaning that if you know what really is new to the patient, you can pick from a wide range of options. If you don't, you can try by picking something uncommon for the same reasons we talked about for commercial foods that are uncommon antigens, just ones that are not as available in the pet food supply. Oops. So we go ahead and we think about, what other options are available. It's not just diet. Well, there are immunosuppressive therapies or immunotherapies potentially. Certainly, I think that the immunosuppressive or inhibition is current practice. We try to use diet, but we sometimes need steroids like prednisone to calm or reduce the immune response. We may use a cytokine inhibitor for things like itchiness, especially with an example of that being Apoquel. Or we might have Cytopoint, which is an antibody as well, to help reduce the reaction that is inappropriate. I've put in here the idea of oral immunotherapy in the future. Certainly some of you, if you are familiar with the Next Immune offerings, one of those is shown under the sublingual immunotherapy, or SLIT, in the lower part of the slide. That has promise and shown promise potentially for skin environmental allergens, and how that can reduce or ameliorate and dampen, if you will, the inflammatory process rather than just dealing with the suppression of it. And one of the current modes that we're seeing in the human side is an allergen powder that has very, very small amounts of peanut. The first dose is given in a very controlled setting to deal with anaphylaxis, and then slowly builds up a small amount to build up some new oral tolerance for peanut allergic humans. That's really not been done in veterinary medicine, but they're trying to prevent a life-threatening allergic reaction from an unknown exposure or an accidental exposure, not saying now you're going to have peanut butter sandwiches. And so when we look at these and we look at our options, we certainly have to consider, is this something that we need to incorporate into the treatment, whether it to be bringing down the threshold to deal with a pruritic patient, or just to calm the immune response while we can currently give a new diet. And we'll talk a little bit about sacrificial diets and why that calming the immune system might make sense. And even though I'm a nutritionist, drug therapy has its role. So just to allude to it again, I don't have a relationship with NextMune, or as we used to know them as Spectrum, but I do want to point out that there are some allergen-specific immunotherapies that have a long history of efficacy. Certainly, many of you may be familiar with them, but if we're thinking about that threshold in dermatologic cases and that pyramid that we showed in the pathophysiology, treating with hyposensitization shots and therapy might be helpful concurrently with diet, so that we're bringing down below that threshold so the patient does have clinical manifestations. And for more information on allergen-specific immunotherapy, I would certainly reach out to NextMune for their literature and their offerings for some of your patients. So we talk about treatment and monitoring and having a little bit of understanding, what does this look like? And so I created a little, if you will, timetable that kind of goes over kind of what we expect with a trial, and how this might be implemented, and kind of the process of monitoring and then adjustment, and then we'll get into more details kind of after this overview. So the challenge, certainly with past food antigens, is something that is the only definitive method of diagnosis, as I mentioned, but it's rarely done for the reasons I said. Eliciting back the pruritic patient, the GI upset, really is something that clients are very rarely interested in doing. The disadvantage, as I said, and I want to highlight again, is that you then may eliminate things that would be tolerated otherwise. So we talk about the change in the diet. We make that change in the diet, and then we might pick a limited or novel hydrolysate diet, and that's really based on diet history. Again, if you don't know exactly what's novel, you might pick a hydrolysate because it hopefully doesn't. It's more hypoallergenic. No intact proteins are hypoallergenic, even if they are novel. We try to be limited so that as we do this trial, where you don't have a lot of variables. Well, maybe they didn't respond because they were giving this other treat, or they were still giving this other food, or there was 3 or 4 different protein sources in the food. We want to be very, very reduced and have as few protein sources as possible. Usually 1 protein source from an animal or plant source, and then 1 from a carbohydrate-rich food like a grain, a tuber, or a legume. Certainly we can use starches and commercial foods that can reduce that antigenicity from the carbohydrate. And we might refine that with testing results. So we talked a little bit about the newer technologies that are coming available with blood testing. Maybe that becomes an available option to say, hey, through this filter, these are better choices to first initially. We have 10 things we could feed. This informs our decision to maybe try these 5 instead, and we think they're maybe more likely. Certainly an area of research that still needs to be done. We then wait for dermatologic signs 8 to 12 weeks. There's debate about this, but certainly a 2 to 3 month time frame is typical amongst dermatologists that I've spoken to over the years, to try to see the calming of the immune response. In GI disease, we are fortunate that we usually see a much more rapid response to know if we're being efficacious. It can be as little as a day. It can be 7 days. Usually after that, if it's not responsive with GI, it's probably never going to be, in my experience. What can be really helpful is if you have a patient that has both GI and dermatologic signs. It's been my experience that if the GI signs start to respond, it can give a foreshadowing that the dermatologic signs are going to be reduced as well, and that can be really helpful. Similarly, if you start to have recurrence of GI signs, it can be a foreshadowing that dermatologic signs are going to be coming back. And so we watch for that time frame, whether it be on the week time frame, the week's time frame, or days time frame, for are the signs reducing or remaining? And if initially we have acceptance of the food, that's really important. If we think about the hyporexia, the reluctance, the finickiness, so acceptance of eating the food can be a good sign. They may be a little hesitant because they go, oh, all these foods always make me feel a bit upset in my tummy. But if they eat it and then they start to eat meal after meal with some more interest, that can be a good early sign. And then certainly improvement is what we want to see. We want to see a reduction in clinical signs and a trending towards that, hopefully a reduction to the point where there isn't any. Now, if we see improvement, but it's not completely resolved, then we might have to think about, some immunosuppression, if we didn't already initiate that. So that can be a consideration. Concurrent therapies, talk about make sure there's flea, adulticide. We may be talking about immunotherapies, as we talked about hyposensitization shots, for example. Those may be needed to help reduce all of the clinical signs as much as they possibly can. If there's worsening after an initial improvement, that's certainly something that may indicate that we need to adjust the diet. So if we see at the top, we can say we just jump right over and we adjust the diet to new ingredients, maybe ones that we think are more likely to be novel, ones that are less common, to see if there's improvement. And we certainly have to remember that if we get full response, ideally we do a challenge, as pointed out in the red circle. That is the goal. We want to have a challenge and to prove what they are actually reacting to so that we can therefore no longer feed that. And then we would go back onto the elimination diet that they're doing well on. But we often leapfrog over to adjusting the diet, and then we hope we can challenge again. But again, that may not happen. So if we look at food refusal, it's really important to understand that it may be related to GI signs, how they're feeling, a postprandial effect, if you will, learned aversion, that they associate the food with how they're feeling. But it could be that it's just the food isn't palatable. It might be a format that they don't prefer. It may not, it might have another concurrent disease. And so we'll go over those briefly here. That we can add things that don't introduce antigens. So we don't have to use toppers that violate what is tolerated or that may not be appropriate for other conditions. And so, for example, things that make food more delicious, more palatable for us similarly work. And so in some cases, more aroma, higher moisture, and we can use warming with warm water to release some of those volatile chemicals that are seen as pleasant, attractive to a dog or a cat. We have to remember, though, that not all will enjoy it being wet, and we'll get to that in change in format, but it's certainly something we can do. You want to safely heat it up. You heat food up too much, you can start to degrade vitamins and create vitamin deficiencies, but just enough to get some of the aroma that can certainly make the food more pleasant and attractive. It's also important in older patients or some comorbidities where their ability to sense and smell has been reduced. That can certainly help. Sugar, sense of sweetness. Now, this doesn't work in cats. They don't have a drive for that, nor do they have a drive for salt. But in dogs, they certainly, just like we do, enjoy the flavor of sugar and salt. Not all to the same degree, but it can be something we can use, and we can use sugar in the form of just pure sugar. Sometimes I get a little bit concerned, we have maple syrup, honey, that seems more natural, brown sugar, but does that have the potential to have a little more antigenicity? Unclear, but it's something to consider. Just to warn people, obviously, not to use artificial sweeteners for fear of xylitol and the toxicity associated with that in dogs and probably cats potentially, and liver. Salt, just table salt, salting the food. Many people like to salt their food, and that can drive. And both pure sugar and salt don't increase or provide any antigens, so they can be added safely. There is a limit to how much can be added, especially if we think about vegetable oil, because of the energy with sugar and oil, we can start to dilute out calories. But a small amount drizzling on can certainly be helpful. So we think about refined vegetable oils. Maybe people were reluctant to use corn oil because of the fear that it is, antigenic. But refined corn oil it really is very rarely eliciting of things. It's fine not to use that. You can use other things, other vegetables, walnut oil, canola oil, all these vegetable oils that are available, safflower oil. Some of them have some linoleic acid, which can potentially be helpful for coat, but remember, they also can be very rich in linoleic, and linoleic acid is an N6 fatty acid, and N6 to N3 fatty acid ratios that are lower can be somewhat anti-inflammatory. So we don't want to go hog wild and put tons of that in, just a little bit. Sometimes people will suggest using ghee. Ghee, if you're not familiar with it, is clarified butter in essence. Whether that takes the milk proteins out completely, if they're allergic to milk proteins, is debatable, but certainly palatability-wise, it can be very, very palatable. Salted butter, of course, it can also bring in some salt and some fat, and fat in general can increase palatability. We can change the format of the food, so wet versus dry, and dry. It's not always, oh, they're being fed dry, try wet. Especially for cats, they may have a fixed texture preference. They may associate just food with dry food and only want to eat dry food, and offering the canned food, they may not be as interested in it. Dogs, it seems that they generally prefer canned food or wet food or retorted food over dry food, but not always. And so trying the different formats can be helpful. Certainly look at other manufacturers. Sometimes just the palatants they use, that's the outside coating that they put on kibble that you can kind of see as a little bit of a greasy residue. That can be different and play a role. Sometimes the base ingredients, there's a lot of little variables that we may not appreciate with our sense of smell that can make a difference to a patient. And then novel or uncommon, certainly we may need to try changing what's being fed for fear that they just actually are reacting to it. Or they may just find certain flavors or smells more attractive to them. If we think about comorbidities, one of the most common things that I see is that a lot of the foods, in order to drive palatability commercially, do have higher fat levels. And in a lot of diseases, there can be challenges with higher fat that also relate to the GI tract. And so just the slowing of the gastric emptying can cause some of that rumbliness, that borborygmy. It sometimes can cause stomach discomfort. And so decreasing fat and therefore improving transit through the GI tract can be different and can be helpful. So dropping fat can be helpful. It is more challenging to find lower fat options, but it can be helpful when you have a patient that is initially not responding well. And then certainly higher fat diets can be contraindicated in other conditions like pancreatitis, and it can be really, really hard to distinguish between the two diseases. A lot of the signs are very similar. The diagnostics are not perfect, even with biopsies, and often we don't have biopsies, certainly not biopsies of the pancreas to be able to identify it. Diagnostic imaging cannot be always perfect. Blood testing, we might have the ability to do B12 or folate and have some suspicion that there's some type of GI disease or dysbiosis, but it's really hard to know exactly that's definitive. Similarly, it can be really difficult, a PL, whether that's fully predictive. And so fat on the back of your heads can be useful in fat restriction to see if you've been feeding higher fat, does lowering it make it improve it? And that can sometimes be a useful strategy to try to see if it's working, and it doesn't have to relate to the antigens in the food. So I think it's important to recognize cost concerns. Sometimes I hear, since I do a lot of homemade diets, oh, I want to do a homemade diet because I think it'll be the most cost effective for me. And in my experience, that is not the case. It's not as expensive as other options, but it is certainly not as inexpensive as extruded or kibble. So I put here, this is a study that looked at some weight loss diets. We have a series of studies I've done with Virginia Tech. There's one that we have received funding for with Virginia Tech, Ohio State, and us collaborating to look at the different costs of feeding. And those abstracts that we've presented and been peer reviewed show that certainly dry extruded food is always the most economical. And the per mcal, if you're wondering what that is, that's per megacalorie. That's 1,000 kilocalories, mega being 1,000,000. So the calories in the metric system, just for reference, is with a small c, is what we think of as 1 calorie with a capital C is 1 kilocalorie, or 1,000 calories. So megacalorie, it's about the amount that an average sized dog might eat. A little bit more than average sized dog might eat is 1,000 calories or 1 megacalorie. So if we think of that as a per day basis, you can see that it can get pretty costly. And there's probably an increase when you look at hydrolysates. And this is a study that looked not at hydrolysates. We know hydrolysates can be very expensive. They might start to tip over into being more in the area of where homemade diets are. We can see that, there's a, threefold factor potentially increase in a homemade diet, especially when you're having to feed an exotic, uncommon, and potentially lower carb diet. So those things all increase cost. The more animal tissue you're using, the more exotic they are. Those are more expensive, especially if you also add in leanness. So generally, a lot of exotic meats are ground meats that are more cost effective. So they have more animal fat. That animal fat actually reduces the cost, and the more protein, the leaner the cut, the more expensive it is. And then finally, there's retorted or frozen. This is data for retorted. So retorted is just canned food. It is the most expensive. A lot of cost in moving water around. And so And it's likely that, although the study didn't look at it based on just awareness of the market, that frozen, foods that are with direct delivery, because the logistics that involves, are typically probably much more expensive than that. So this kind of gives a flavor of, the direction. If you want to be most economical, uncommon antigen diets that are extruded dry food is going to be your best choice. Then maybe hydrolysates extruded, then homemade, depends on the hydrolysate, then retorted, and then finally the most expensive, probably fresh delivery would be your most expensive option. So we're going to talk a little bit about some of the data we have, just to kind of help us understand, where sometimes failure of diets might be. It may not be a failure of diet history. It may not be a failure of treatment. It can also be just that we don't exactly know what we actually have been feeding or have chosen to feed, unfortunately. And so we have some data looking at foods, looking at ELISA testing, looking at DNA testing, to try to see, are the ingredients or the ingredients of concern, are they present or not? And so when we look at this and we look at the ingredients of concern, we have, ELISA testing that helps us with identifying if there's antigens that are not in the ingredient declaration or list. And if we look at the work that Dr. Raditic and Remillard did, they did find, unfortunately, some common antigens in foods that should not have been there. And then more recent work by Pangini et al. Looked at cross-contamination even in limited ingredient canned diets, specifically designed for treatment. And so overall, we know that over-the-counter foods may have common undeclared food antigens. And this isn't something where they're doing something with malfeasance or inappropriately. It's just that they're not cleaning out probably their production line, their packaging line, as they switch over. There's also something called rework, which is material that you might incorporate at a small amount into it, and that may or may not, in small enough amounts in GMPs, may allow for you to use that. And so you could have antigens that are not appearing on the ingredient declaration or a list of a pet food. What does that mean? What does that translate to us? Well, it means that your diet history may not be accurate in describing all the things that have been exposures. It could mean that you're also feeding a food that is introducing antigens that you didn't think you were feeding in your elimination trial. And there's always this debate about, animal fats, and do they represent antigenic concern or not? And generally, I think that a lot of the highly processed refined vegetable oils probably don't. Animal fats, depending on how they're processed, may still have some antigenicity, certainly something to consider. So if we look at a little more depth, what Dr. Remillard and Raditic reported, I won't read you the whole thing, but you can see that 3 of the 4 over-the-counter venison canine dry foods with no soy products named in the ingredient list were ELISA positive for soy. So if soy was an allergen, that would be certainly concerning if you're picking OTC food to avoid soy and picking this venison diet, thinking you were not going to be feeding it. Additionally, 1 OTC diet tested positive for beef protein with no beef products listed in the ingredient list. And this also introduced the idea of cross reactivity. If we have a similar species, there's always a concern, did the patient react to the antigen that they were exposed to, or was it so similar that they're reacting to it because even though they've never been exposed to it? So for example, bison and beef, if I develop a beef allergy, does that bison protein look so similar to my immune system that even though I've never been fed bison before, when fed bison, I'll react to it as if I was being fed beef? And that's called cross-reactivity. They also go on to point out that 1 over-the-counter venison diet was not found to be positive for soy, poultry, or beef protein. So it wasn't all that they were able to find the ELISA being positive for. There were exceptions. But then they note, however, none of the 4 OTC venison diets could be considered suitable for a diagnostic elimination trial, as they all contain common pet food proteins. So they have proteins that were common and really were not pure enough. And if ELISA could react to it, which is similar to how the immune system would react to it, we would be concerned that they would react to it. And they go on to identify that there were things that were not present in the label. So OTC foods probably are not suitable, at least based on this data, to be used for an elimination trial. So what about, looking at foods that are designed to be antigen limited? Is this how this paper looked at it with Pangini that I referenced? And you can see this table really gives us an idea of kind of the challenges that might exist. And so if we look at the green shading, those are the declared animal protein sources. So we had horse. This is a European study, so they do use horse meat there at times for food elimination trials, even commercial foods, not something that we do here in the States anymore. And then you can see that there was none, meaning there was no animal protein source because it's a vegetable or vegetarian diet. Tuna, horse again, and then hydrolyzed chicken, so hydrolyzed diet. And then if you look in yellow, there's a declared fat source. So I use oil as kind of think of as fat. There's chicken and fat, fish and fish and fish. And so, if you had a concern about the antigenicity of, chicken fat and chicken, you have to keep that into consideration with a horse diet is their point. Similarly, there's a deer diet where you have to consider that there's fish there, and so fish allergens were a concern, and you're feeding venison or deer, does that represent a concern or not? And then you can see that they did a PCR analysis, and in many of the cases they were able to find other species DNA. And you can see that in the turkey there was chicken, maybe not surprising in a poultry-based diet. In the horse, it didn't show up and show anything but horse, which is great. The red one I'll point out is the duck. The duck, it showed up and it didn't have any duck DNA. It was turkey, chicken, and horse. And so there's a question about why didn't that become positive? And then if you look at the quail, there was some other avian species that wasn't quail that they couldn't identify. And then finally the duck, again, they had the last diet, sample 11, it did have duck, but it also had turkey and chicken and pork or swine. And so, the concern of cross-reactivity becomes one of concern if you were trying to avoid turkey and chicken, and then also just a species that you weren't expecting to see present in there. So there's a lot of concern even with some commercially prepared therapeutic diets, as this paper suggested. And then you can see there are some that are, did exactly what they said they were going to have and not have ingredients that would be concerning. So there's been some additional work by others. I'm just highlighting some of the statements. I'll read the red highlighted portions. In this Cox et al. Study in 2020, it said unlisted DNA most frequently detected was lamb and canine diets and turkey and feline diets. And so these were raw meat-based diets. And so they suggest that raw meat-based diets can be used because there was ingredients that were being shown that were not supposed to be present because they weren't even listed on the ingredient deck. The Ritchie et al. Study from 2018, you can say that they 40 analyzed products, 9 dry, 22 wet, 6 dry, 3 wet, and those are novel protein. That's what the MP is. The HP is hydrolyzed protein diet. So these are therapeutic diets. 10 presented, so 10 out of 40, content that correctly matched the label. So better than we've seen with OTCs. Unfortunately, 5 did not contain the declared animal species, which is troubling that 5 out of the 40 didn't have what they said was in there. And then 23 revealed the presence of an undeclared animal species. And the most frequent contaminants, as they referred to them, because they weren't on the ingredient deck for these diets designed for food allergy, or pork, chicken, and turkey. And so certainly raises the concern about undeclared animal species being present and the challenges that maybe why there's not a response if one of those undeclared animal species or protein sources is something that the patient is reactive to. We also have, and I probably will butcher this last name, Horvath, Ungerbok, et al. Study in 2017, and they found 9 of the 10 over-the-counter diets that they looked at had DNA of 1 or more animal species other than the declared on the label was identified. And they said the 2 hydrolysates, and this is where we have a green because this is a nice positive thing, and I alluded to the fact that there may be a benefit of hydrolyzed protein. 2 of the hydrolyzed diets only contain DNA of the declared animal source. So that's good news. So how do I actually go about doing this? I did a little bit of a timeline, a generic timeline, but how do I do this? And I would say how do a lot of board certified veterinary nutritionists do this, who are often, consulted, at the second or third step of what I'm going to talk about. So the first step is what a lot of, I think, general practitioners, even veterinary specialists, internists are very comfortable with, which is they first try a commercial diet. And they often will pick an hydrolysate if it's an unknown diet history or they don't believe the accuracy of the diet history. If you have a really good diet history and know what has been fed, a novel therapeutic is fed. So we don't pick OTC foods, we pick a novel therapeutic with the understanding that although there have been some data to suggest that there could be some concerns, in general they are better. We believe that the manufacturer is working hard in the facility to prevent cross contact, not use reworked material, et cetera. So it gives us our best option. And as we said at the beginning about our options, it's our easiest option, most convenient option. Then the second, when that fails or doesn't work, often folks will pick a homemade diet, but often it's deficient. So they'll give a homemade diet where they use limited ingredients, things that have not been fed before, hopefully, and then be very careful about not giving any treats or flavored medications or toothpaste or supplements. Can't tell you how many times people will be giving treats that they don't account for and think about the antigenicity of that in the midst of a trial, an elimination trial, and go, oh yeah, or flavored toothpaste or flavored medications, flea preventative is a classic one, heartworm preventative. All those things need to be considered and eliminated, and a non-flavored option provided. When that works, or when folks believe that that might work, often there's an attempt at a homemade diet with one variable at a time. And so that usually means that you've kind of gotten to a point where the homemade diet has been fed, but you now want to add back in things, especially supplementation, and you're going to try to fortify the homemade diet because commercial options aren't working. You think the homemade diet is working, and now you're going to try to really work towards the long-term methodical diet that will work, and add in the things that are needed, either due to preference or because of the need for fortification. So just a comment about one other thing that I commonly see, which is, we talked about palatability, but sometimes some of these diet strategies can lead to some soft stool in patients that have had no soft stool. And I'm not talking about really bad diarrhea, I'm just talking about soft stool. And I don't believe that's an early manifestation at times of actually some type of adverse food reaction. Instead, I think it's a reflection of that there is just not enough fiber. And we have to remember that there's total dietary fiber, and that's made up of two components, insoluble and soluble fiber. And there's a sweet spot, that's what this little Venn diagram of where stool quality is really optimal. And it's a combination of the total amount of fiber, but also the fraction of that that's insoluble and the fraction that's soluble. And it's a reminder for all of us going back to our nutrition days and maybe vet school or tech school or wherever we came back, insoluble fiber is a firming fiber, and it hardens it, but it's harder to find as well. And a lot of people, humans, don't need to firm their stool, and we usually reach out for powdered cellulose. We have a lot more options for soluble fiber, a softening stool, a laxative effect, if some people think of it. It also can often be fermentable, and thus a prebiotic. Prebiotic meaning that it is a source of nutrients for probiotics, good microflora, as we used to call it, or microbiota, to help the overall microbiome. And psyllium seed husk is typically used, and it's about 2/3 soluble, 1/3 insoluble. Powdered cellulose is purely insoluble, for reference. And so we have to try to figure out how we can get the right kind of proportions in the total amount, always looking for guidance on exactly the dose. Every patient is unique, and so titrating to effect is usually my approach. I'll reach for, if it's just powdered cellulose, and slowly do a small amount, depending on the patient, a quarter of a teaspoon a day, and look for improvement. If the stool is improving, it's getting a little bit firmer, I will continue on that trend of increasing the dose, as long as it doesn't affect palatability. Obviously, you can overshoot things. You could cause constipation. You could cause too loose of a stool with soluble fiber, but somewhere in that sweet spot, hopefully you can titrate and look to the effects of the GI tract without changing the base diet. Because a lot of these base diets are low residue, meaning they have a high digestibility, a very low fiber content, especially homemade diets. We talked a little bit about the comorbidity and one of the common ones with fat. So I just want to highlight that, fat restriction can be necessary at times, even if there's no known past fat intolerance. A lot of the therapeutic diets can be higher in fat to drive palatability, as I alluded to, and it can be helpful to try to drive the fat level down. More so in dogs, in my experience, than cats. And so I put the cat reference, the dog reference for the amount of calories we're considering. And these are fat calorie percentages. This is really important. That's not the label guaranteed analysis amount, which is just the mass of it. So fat calories enables us to compare apples to apples, because if you look at the amount of fat in a canned food, it'll look like it's much lower than a dry food on average, but in fact the dry food will be lower. You might see 4% on a canned food and 12% on a dry food, for example, and that canned food could be 10, 15, 20% more fat calories, and very significant clinically. If you're not familiar how to convert, all the product guides from the therapeutic will provide you that as percent ME, or the caloric distribution, they may refer to it, or the fat calories, and you can find that. If you're not clear on that, you're certainly welcome to go to a site I have, balanceit.com. Under help, there's a guaranteed analysis converter. You can put what's on the label and it'll convert it to you. There's no charge for that. It's just, I got tired of telling people how to do the math. So slight fat restriction would be around 20% fat calories. There's just a handful of commercial options that fit that category. If you start to go below that, 16 to 18%, there's no uncommon antigen commercial options. There are commercial options, but they're not, unfortunately, made with novel or uncommon antigens. I put a couple there. So there's Hill's ID, the Rokinin, gastrointestinal low fat, or LF, some people just abbreviate it to. Those are in that neighborhood of 16 to 18%, but they, again, use very common protein sources and antigen sources. So if that's a concern and you can't use those because they're not novel to the patient, then you're pretty much stuck with making a homemade diet. For severe fat restrictions, there are no commercial options, not even therapeutic options, because the palatability becomes very challenging. And so you have to make a homemade diet if you need that level of fat restriction. That's pretty rare. That would be the hyperlipidemic patient. That's usually a patient you do know about having fat intolerance. So if you do need to make a homemade diet, what are your resources? A few I have available here. Certainly I have a conflict of interest, as I alluded to before, as I'm a co-owner and the founder of Balanceit. And also we maintain the listing at vetnutritionist.com that's widely used to find referrals. We don't have a relationship with anyone except for, of course, my resident, Dr. Okada, who I alluded to before, who sees cases in Northern California, north of San Francisco. So balance.it, if you go there, there are trillions, yes, with T, of recipes, both for sick and healthy animals. They're fully customizable. You can get it with a combination of human supplements to fortify the diet. So there's nothing to be bought there. We make our money by selling supplements because we think they're more convenient, but certainly that's a good resource and widely used, as I alluded to. Petdiets.com, that's run by a boarded nutritionist who has also some other board nutritionists that works with her. She did one of the studies you saw before, Dr. Remillard, and it's $25 for the first recipe and then $12 for the second recipe and thereafter. They have about 100 recipes. Unfortunately, they're only for healthy animals and they're only semi-customizable. You can't change proportions, amounts, etc., like that, where you can on the balance.it site. Vetnutritionist.com, if you need that next level of help, there are a whole bunch of board certified veterinary nutritionists who do those types of consultations. They'll review the medical record, they'll take a diet history, they'll evaluate that and really give a very, very gold standard solution. One option to find a listing of that is vetnutritionist.com. The prices range from $200 to $700 per recipe, and of course there's infinite number of recipes in that, and they mainly focus on sick pets. They'll usually refer to things like balance.it or pet diets for healthy pets, in my experience. Oops. So fortification is really important. We have to remember that has to be done. And why does it have to be done? Human foods need to have minerals and vitamins added because we don't typically feed the bones and blood and raw liver that are rich in minerals or rich in, vitamins. And so we have to make the diet replete, put those back in, because we're not feeding whole prey. And even though dogs are omnivores, they still eat a lot of internal organs and spicules and eat bone marrow and get a lot of calcium from their normal prey, using the wolf as a model. Certainly cats with small avian species and mice eat the whole prey species and get all the internal organs and bones and get the nutrients they need. This is just a screenshot on your right that allows you to see the nutrient profile. This is from balance.it, where you can see with and without supplement. It's a nice resource to see the red bars showing the deficiencies and the degree of how far down they are. Closer to the left indicates the degree of deficiency. And this is just comparing using mainly USDA database for human foods, and then NRC or AFCO nutrient requirements. So it's just pure math to show a client, here's why you need to fortify it if you're going to feed it long term, so we don't create a deficiency. So I alluded to the fact we're going to talk about sacrificial diets. And so this is the idea that we, in the midst of a crisis, when there's a really bad disease, a really bad immune response, we're going to feed something that is novel to the patient, or that we don't mind feeding, not feeding again. And we don't want to feed something long-term that is in essence something that is easy for us to get, cost-effective. And so we feed something really exotic, really unusual, so that if they are really prone on level of the gut, especially, to developing new adverse reactions, and those can happen as little as 2 weeks, that they're not being exposed to them and then having them eliminated. Rather, we give something in the midst of that and immunosuppressive drugs so that we can calm the immune response, not make it as reactive, not have the gut be leaky, if you will, because it's been damaged, and therefore then more reactive in developing new antibodies to whatever it's being introduced. And so this is really important, especially in young patients, because we will run out in the course of their life. Food allergy is tough to deal with, but it is not a life-threatening disease typically. And so if we have a patient very young and we have a decade ahead of us, if it's as quick as every 2 weeks to develop an allergy, we don't want to be having to scour the earth for zebra meat or some African squirrel meat, which is something I had a client looking for at one time because they were just running out of options of what was novel. That's also the promise of hydrolysates. I think if you get to that point, certainly a consideration of an elemental diet would be worthwhile. So in humans, they have elemental diets where they've broken it down into peptides and amino acids. It's kind of the pure, complete hydrolyzation process. It's very expensive though, but maybe not as expensive as sourcing zebra meat. So the goal, obviously, is to reduce medications. I'm a nutritionist, and I want to use diet to treat everything, but I'm a realist and pragmatic and recognize that is not the way that it always works out. And so if we can reduce it and reduce the side effects of those, that can be helpful. The cost at times, that can be helpful. That can be a client's driving force. But we have to recognize that it really is important that immunosuppressants, immunotherapies are used where appropriate and where they are helpful, and they may need to be lifelong treatments. So with that, this is a format that doesn't allow for live questions, but I do appreciate your attention. It's been a pleasure talking about something I'm very passionate about. These are just some nice images around where I am in Northern California of the state capitol, a Tower Bridge, and a record company that was very famous at one time called Tower Records. And I guess my dog is barking to tell me it's time. It's for me to complete my talk, and I wish all of you a good rest of your morning or afternoon or evening, depending on where this finds you. Take care.